Okay, today I'll lecture in discipline propedeutics of therapeutic dentistry. And today I'll tell you about history of therapeutic dentistry, this anatomy and dental formula. Plan of our lecture today will be historical stages of the development of therapeutic dentistry, its sections, historical, clinical, and anatomical structures of this dental formula, and science of this. First of all, the history of therapeutic dentistry, the main stages and the main key moments. The presence of decay was documented in teeth from skulls dating from around 25,000 years ago, while the first written sources that bifid to decay can be found in a Sumerian paper from 5,000 before Christ that speaks of dental worms. You can see the ancient types of dental treatment. The next, in Italy, the Guild of Barbers was established in 2071 in the Republic of Venice. Proof of the central role of barber surgeons, sometimes also known as Terulzi, from Greek, for hand, and agon means work, which then became and later circugo, and finally circuiso. The fact that is considered to be the first book on dental practice. It would be fun and interesting to look at the history of dentistry and how things have changed from ancient times to contemporary moments. The practice of dentistry is rooted in ancient times. However, dental care was still pretty grim prior to modern times. Dentists used crude restorative and surgical techniques, and most available treatments were likely administered by frauds claiming to be a dentist. The treatment usually failed, and death from dental infections was not uncommon. Without effective pain control techniques, dentistry was hideously painful. Pain control consisted of brute force being held down on a knee to the chest, alcohol. There was no way to control these remedies, though patients were either under-medicated, over-medicated, or died of explosion of shock. The next stage in development of therapeutic dentistry, it was the tractate or book about the first steps of dentistry. However, the very first book devoted entirely to the dental discipline had seen the light at the early as 30 in Germany, written by Boucher, which include topics such as dental hygiene, dental extraction, dental drillings, and the laying of gold fillings. This book accompanied all dental branches. From therapeutic dentistry to surgical dentistry, except pediatric dentistry and except orthodontics. 7,000 BC evidence of drilled teeth found in human remains from the Neolithic period. 5,000 before Christ, Romans wrote about tooth worms causing ashes and were skilled at preparing teeth with gold crowns. 3000 BC, earliest reported dentist, Hezire, also known as chief of the toothers. Uh, the 700 AD Chinese developed silver paste to fill cavities 1000 years before the Western world did so. 2010, dentists were classified as surgeons, performed surgery or Baber surgery, performed tooth extraction, trims hair, and shaved faces. 1700, Pierre Fouché, what they considered the father of modern dentistry. According to that time, development dentistry is an independent profession for medicine. He introduced materials to fill teeth, insisted that sugar and acid cause decay, and discovered that untreated cavities lead to tumors around the teeth, and first introduced dental prosthetics to replace missing teeth. It was the father of dentistry. 1770, Paul Revere was a silversmith who later became a dentist. George Washington was reported to have wooden teeth, but they were actually dentures made of animal and human corpse teeth, without knowledge about artificial materials for artificial crowns. 1944, inhalation anesthesia was discovered. Anesthesia theory was discovered. Patients inhaled ether or nitrous oxide to eliminate pain during dental treatment. 1980s, the collapsible metal tube revolutionized toothpaste. Before then, it had only been available in liquid or powder form from dentists. 1985, first dental assistant, known as a lady in assistance, first came about so a woman patient could go in dental office unaccompanied and be in the room with a male. 1985, dental x-rays were discovered, which revolutionized and changed dentistry forever. Because before development, the x-ray investigation, the dentist and other doctors too can't understand the processes and can't see the processes under the gums in the bone. 1905, Novocaine was invented as the first local anesthetic for dental treatment. And Novocaine today, some dentists can use too. 1930, first dental hygiene school to train people in preventative dental treatment. 1984, first toothbrush with synthetic nylon bridges was invented by DuPont. Before then, toothbrushes consisted of a toothstick made of twigs, 3000 years BC, hawk bristles, 619 AD, horsehair rubbing erect with a salt of teeth, and then boar hair bristles. 1945, fluoride was added to water and the rate of cavities drastically decreased. 1980, dental implants were being placed with some success. 1985, 1989, first home teeth whitening was introduced. And a few words about contemporary or modern dentistry and modern dental principles. Even though raw dentists, we don't just care about your mouth, we care about your whole body health. I think that you know already that dental health and somatic or general health have a very strong connection, and normal condition of oral cavity can't exist without normal condition of general health. It is fact for today. An essential part of our approach to dentistry is to enjoy your comfort and that every procedure benefits your entire body. Some of our practices include using fluoride-free prevention products, minimally invasive procedures using biocompatible materials, ozone therapy, safe removal of amalgam fillings using the least toxic materials, sleep disorder screening and testing, TMJ or temporomandibular joint disorders prevention and treatment, and much more. The main goal is to provide you with exposure to the least amount of toxins possible while also preserving the natural teeth. Today, the principles of dental treatment changed relatively the ancient times, the last decade even. What about the dental specialization? Therapeutic dentistry, surgical dentistry, orthopedic dentistry, and pediatric dentistry, and orthodontia. It is the main branches of dentistry, and the main specialization of dentistry. If you don't have the questions about historical stages of dentistry development, we continue, and today you will learn about the main two structures and the main components of the two structures. You know that each tooth consists from enamel. It is the external part of each tooth. Of dentine, it is the base of each tooth, and the pulp. The pulp, it's a soft connective tissue which exists into the tooth and has different functions. For example, it's functions of defense, it is functions of trophic, it is functions of repairing and other. The main components of enamel. First of all, enamel shares some mineral characteristics with bone tissue, bodies, and enamel matrix is deposited in columns formed by cells called enamel. Is the strongest substance in the human body due to its high mineral content, listed in table which you see on your screens. Due to its high mineral content, like bone tissue, they small mostly, but instead of fibers, enamel contain proteins, including amelogenins and enamelins. It's not collagen because it is the proteins which have another 3D structure of the protein. Components of enamel. It is tissue or structure of the tooth without cells, no cells in enamel, and 0% of cells in enamel. 94%, 94 or even 98%, it's a mineral, ECM or extracellular matrix. It's a calcium hydroxyapatite. Little content of enamel minerals can be, for example, it's all non-organic compounds which exist in the human body. But the main percent of mineral compounds, it is the calcium hydroxide or calcium hydroxyapatite. About proteins, I told you early, and the proteins, it's about 4% from general compounds. Protein and water. Proteins in the water, it's a 4% in enamel. Please put your attention on this slide. The extracellular matrix or enamel is laid down in roots next to other roots. Each root is secreted by one cell. In contrast, bone tissue is deposited in a circular layer, upper circular layer, each cell working only in one layer. The enamel, composed mainly of hydroxyapatite, an inorganic substance, highly mineralized and aligned in roots to provide maximum protection to the underlying dentine. Or it is defensive cover of dentine. Mature enamel is acellular, it is non-lethal and non-sensitive. Enamel cannot regenerate and cannot be replaced. But in the enamel exist the processes of demineralization, and in the repair frame we can tell about the next process, it's a mineralization. These two processes have strong connection between each other. The first process, or demineralization, leads to missing the mineral compounds from enamel or by enamel. The next process, mineralization, means the repairing or restorative process when mineral compounds from the cellular came back to the enamel. These two processes exist after tooth eruption, when you can see the crown of each tooth in the oral cavity. And these processes, mineralization, supported by saliva. On this photo, you can see the enamel. It is an image from microscope. During embryonic development, ameloblast works on a circadian rhythm, depositing ECM and a regular pace for 4 days, then changes speed. The changes in speed leads to changes in enamel density, which can be seen as horizontal lines of red source. Another pattern is visible because ameloblasts don't create enamel wood in a perfectly straight line, but change the direction slightly over days. This leads to the pattern known as Hunter-Schreger bands. The border between enamel and underlying dentine is a distant line named the dentin-enamel junction, DEJ. Ameloblasts are lost during tooth eruption and are therefore not found in the adult tissue. As a result, enamel doesn't undergo remodeling the way the remodeling unit maintains bone tissue, though live. Enamel in the embryonic period is produced by specialized epithelial cells, the enamel or ameloblast. During development, the ameloblast cover the entire surface of the development tooth with a amorph matrix rich in proteins, acellular and avascular. Then is filled with ribbon-like crystals or carbonate hydroxyapatite. These crystals are organized in the root and interroot space away from the dentine. In the second phase of enamel maturation or mineralization, ameloblasts form tight junction and membranes enfolding from the apical ends of the cells, changing the pH from mildly acidic to near physiologic, allowing the crystallization of the matrix. Oh, I'm sorry. Mature enamel is organized in long, thin roots of hydroxyapatite crystals. The enamel covers coronal dentine, while the radicular dentine is covered with cementum. Dentine, it is another structure of each tooth. It is the base. And this tissue that form the tooth from the dental crown to the tooth root, situated inside the enamel and cementum. It is softer than enamel, a small tube filled with tissue fluid called the dentinal tubule runs inside the dentine. Dentine is produced by specialized cells called odontoblasts or fibroblast because the dentine is connective tissue, mineralized connective tissue. Odontoblasts, they rely on the matrix inside closely packed tubules. Those structures will undergo mineralization, giving structural resistance. The periphery of the dentine is composed of odontoblasts arranged in the peaked fence fashion from the underlying pulp and have a cellular processes extending into the dentine's tubules. This structure gives sensitivity to the dentine that produces pain when the protective layer of enamel is eroded. In response to physiological, pathological stimuli, odontoblasts can upregulate this their protein synthetic activity, or have ability to regenerate and to repair the dentine structures. Dentine composed by cells. It is cellular structure, cells odontoblast, bodies in pulp, which have the bodies in pulp, odontoblastic processes in dentine. 70% mineral ECM, calcium hydroxyapatite, 30% protein ECM. You remember that ECM, it's extracellular matrix. It's a collagen, mostly type 1, 3, and 5, and water. And now you can see the photo from an electronic microscope, and you can see the thin structure of dentine with dentinal tubules. You can see these tubules. Dentine-like enamel is a vascular, but it should not be called a cellular. Dentine matrix is deposited by cells called odontoblast. These cells, or more accurately, their cells bodies, are found within the pulp cavity immediately adjacent to the dentine. Each odontoblast has an arm-like of protrusion process called an endoplastic process that extend nearly the entire thickness of the ECM that cell secreted. The odontoblastic process secretes more dentine in a soft form that hardens later, as well as a fluid called dentinal fluid into the space known as a dentinal tube. Dentine is not as strong as enamel because of its lower mineral contents. 70% it's a mineralized matrix or material, 20% of organic material, and 10% of water. You can meet in enamel. Both dentine and pulp are derived from the dental papilla, tooth jaw. Dentine is produced by odontoblasts as predentine as a mesenchymal products composed of collagen fibers, mainly the 1, 3, and 5 types, and proteins. The latter regulates the mineralization of dentine because it is acidic and highly attractable to calcium. Initially, calcium hydroxyapatite forms as globules within the collagen fibers of the predentine that disappear though the entire matrix. Please look at the screen and the slide. It is the real photo of dentine received from a microscope after microscopic investigation of this structure. Later, a second mineralization process occurs with the progressive expansion of the crystals until they almost fuse with each other. That creates the globular dentine and the interglobular dentine, which is less mineralized. Similar to the lines of Retzius, dentine is deposited at different rates of days, which creates bands called the imbrication lines of Ebner, of von Ebner. These lines run perpendicular to the dentinal tubules. Exceptionally pronounced imbrication lines are named the contour lines of Owen, and occur with changes in nutrition, such as during childbirth. You can see the dentine, predentine, dawn of predentine, and the pulp. And you can see how the dentine organized. Unlike cartilage bone and cementum, the odontoblast doesn't entraped in the dentine matrix. Instead, it has long cytoplasmatic extensions that enter the matrix while the body stays on the pulp dentine interface. Then the growth of dentine occurs, though the entire life of the tooth, like enamel dentine, is ever-smooth. The nutrition comes within the odontoblast by enamel, by the dentinal tubules, by the transition from the blood vessels in the adjacent pulp. Within each dentinal tubule runs dentinal fluid, the odontoblastic cytoplasmic process, and efferent exomes. The nerve called the nerve cell associated with the axon is located in the pulp near the odontoblastic cells. The next structure is the dental pulp. Dental pulp exists in the pulp chamber. Pulp chamber is composed of an indeterminate type of connective tissue, but is a soft type of connective tissue, although it most resembles areolar connective tissue. The most common cell types found within the pulp core are fibroblasts and mesenchymal stem cells, which leads to the reparative processes and which supported reparative processes in the pulp and in the dentine. The pulp holds the blood, nerve, and lymphatic supplies for each tooth. The pulp has four layers that appear distant when using and hematoxylin as stain. Dentine, you can see with the gray color on this picture or scheme. The next layer is the layer of fibroblast. It's a peripheral zone of pulp. The next, though named though without cells or non-cells, though, and you can see the pulp core with different types of vessels. It's blood vessels, and lymphatic vessels too, micro vessels. Pulp is the inner part of the teeth, is composed of connective tissue. I told you about that. And the pulp exists in the coronal part of each tooth and in the root, in the each root of each tooth. The next zone or the next structure, it's a cementum. Cementum covered the root dentine. This is tissue covering the top face of the tooth root. It connects the alveolar bone with the tooth by the periodontal ligament. Its hardness is similar to bone. Cementum forms a thin layer between 15 to 200 micrometers see below over the top face of root dentine, which is roughly the width of hair. The ECM of cementum differs significantly enough from a male that the two can be differentiated by their color. Cementum is yellowish in hue, enamel has no color. Both cementum and dentine yellowish make of both cementum and dentine are yellowish, making those too difficult to differentiate by color. The ACM of cementum is disposited by cementoblast, which can be found on the surface of cementum, though alive. And the result, the thickness of cementum can triple in thickness between the ages of 10 and 70 years of age. This is not the same as bone remodeling. as it does not involve the activity of resorptive cells in addition to cementoblasts. Cementum incorporates more fluoride than the other hard tissue. There are two types of cementum, cellular and acellular. In cellular cementum, a cementoblast became trapped within the ECM and differentiate into cementocytes. In the mature tissue, cementocytes are around within lacuna, similar to bone tissue, however, can locally only extend in the direction of the vascular periodontal ligament, or PDL. In the opposite direction is a vascular dentine, which cannot provide cementocytes with nutrients. Cellular cementum is found in the apical half of the root. Components of cementum: cellular cementum, apical portion of the root. A cellular cementum exists in the coronal portion of the root. 50% mineral compounds or mineral part, calcium hydroxyapatite. 50% it's a protein, collagen, and glycoproteins mixture and water. A cellular cementum does not contain cementocytes and any other cells and can be found in the coronal half of the root, as well as underneath the cementum, the apical portion cementum is around 50 micrometer thick in the coronal region and 20 micrometer thick in the apical region. The next structure is the periodontal ligament. The periodontal ligament, or PDL, is a region of dense, regular connective tissue that connects the cementum to alveolar wall. The white color marked the dentine, and the gray color, it's the one of periodontal ligament with the cellular and the fibers, mostly collagen and elastin fibers. Sharp-based fibers extend from one side of the PDL into cementum and on the other side of the PDL into alveolar bone. Like this, the dentine junction, the border between the cementum and periodontal ligament is blurred to their shared lineage. Clusters of rouge epithelial cells can be found within the PDL with a name, the epithelial rests of molasses. The PDL has a much higher degree of vascularity than other ligaments. It also has a more diverse and numerous population of cells. This slide shows you the microscopic photos with the root, dental pulp, dental root, dental periodontal ligament, and alveolar bone. Alveolar bone contain compact bone tissue with a semi-unique feature of many tiny holes of which sharp-based fiber from the PDL insert, as well as larger holes for the nerves, blood, and lymphatic vessels that exist bone tissue and enter the apical foramen of a tooth. This makes the surface of the alveolar sulcus appear porous, which is almost unique for the surface of bones. The porous surface is called the cribriform plate, which is not be confused with the other region of compact bone riddled with tiny holes. The cribriform plate, the ethmoid bone. Cementum, periodontal ligament, and alveolar bone. It's a supported tissue which around each tooth. What about microanatomy? I told you yet. Now, please put your attention on the slide. You can see the macro anatomy tooth parts. It's a crown, the neck, and the root. Except this microanatomical part exist in other surfaces and in other structures such as occlusal surface, enamel, gingival sulcus. You can see it on this scheme, on this picture. It's a cementum at the thin layer which cover the dentine of the roots. It's the periodontal ligament which exists between the cementum and alveolar bone. You can see the root canal. It is the radicular part of the pulp or the pulp chamber, and apical foramen. Though apical foramen in the pulp, you can find the blood vessels and the lymphatic vessels and the nerves. And what about this anatomy? The number of, the quantity of teeth, the groups of teeth. First of all, you have to know their direction in the anatomical direction of each structure. In the oral cavity and the teeth, it's not exception. It's a mesial direction and distal direction. You can imagine central line, which was which will separate the right and the left sides of our body and of the jaws too. And the next picture shows you the groups of teeth and the surfaces. In the permanent dentition, you can find on the half of the jaw, of each jaw, two incisors, the first and the second, one canine, two premolars, the first and the second, and three molars. The last or third molars often called the wisdom tooth or wisdom teeth. And what about the surfaces or the sides relative to the structures in the oral cavity, situated in the oral cavity? It's a lingual surface, it's a labial surface, and it's a buccal surface. Buccal, surface, labial surface. It's a surface which you can see in the frontal, incisors, and canine. Starting from first premolar, you can find, or you can use the term buccal surface. What about teeth? Concretely teeth surface. You can see upper or maxillary and lower or mandibular jaws, right and left sides. What about upper jaw or maxillary? You can find incisal surface. Incisal surface have two incisors and canines. Palatal surface. buccal surface and occlusal surface. More premolars and molars have occlusal surface instead in incisal surface that you can see on the incisors and canines. The next surface we continue, and I hope that you continue to put your attention on the slide. Lower jaw or mandibular. The molars has lingual surface, incisors too. All lower teeth has a lingual surface. The next, it's each tooth on the upper jaw and on the lower jaw has a distal surface of prominent mandibular and second molar. And each tooth has mesial surface of prominent mandibular second molar. It's for example, prominent mandibular second molar, its mesial surface, and for example, distal surface of prominent mandibular second molar. But you have to remember that each tooth has these surfaces. What about dental formula? You can see dental tooth card with the main dental formulas. But for today, contemporary dental formula was pronounced and approved by World Health Organization. It's international dental formula. And you can see this formula which marked on this picture with the red color. This formula or each tooth number or tooth code consists from the quadrant, the first quadrant, second, third, and fourth. First quadrant situated on the upper or maxillary right side, or it's the right side of the upper jaw. The second quadrant, it's the left side of upper jaw. The third quadrant, it's left side of lower jaw. And the fourth quadrant, it's right side of the lower jaw. And the next number of the code, it's a number of teeth from the central line to the last teeth in the half of the jaw. For example, the 11, it's the first upper right incisor. The next example, 37, it's a lower left second molar. And you have to know that each half of each jaw has 8 teeth maximum. The first incisor, it's the first tooth, the second incisor, the second, the canine, the third tooth on the half of the jaw, the first premolar, the fourth tooth, the second premolar, the fifth tooth, the first molar. It's a sixth tooth, the second molar, it's a seventh tooth, and the third molar, it's the eighth tooth. I think that it's not difficult for you, and it's not difficult for understanding. The next slide demonstrate to you the implementation of international dental formula by WHO to their practice. its jaws, the real jaws, upper and lower, and you can see the situation of each tooth relatively this formula. Remember, please, that the first quadrant is the first quadrant and the fourth quadrant in the it is the right side of the jaws, and the second quadrant and third quadrant means the left side of the jaws. What about tooth anatomy, tooth and features of the tooth surfaces? I think that you remember this from anatomy. Please, I want to tell you about the common features, anatomical features of different teeth. First of all, you have to remember that exists maxillary arch and mandibular arch. Each arch consists from the same kit of the teeth. The same kit means that and upper jaw and lower jaw, it has central incisors, has lateral incisors, has canine, and had another premolars and molars. The incisors, upper and lower, and the canines, upper and lower, have one root. And the features of coronal anatomy. I hope that you remember from discipline, which you learned the last year. What about premolars? I want to tell you that upper first premolar has two roots. Upper second premolar has one root. Each lower premolar has one root. It is the main information to you, I think. And what about molars? On the slide, you see the upper molars. Each upper molar has three roots. Two buccal roots and one palatal. Each lower premolars has two roots, nasal and distal. I can't tell you about, I can't tell you exactly about the quantity or the number of roots when we discuss the third molars or wisdom teeth, because it's very individual for all of us. Very individual tooth, which has very individual number of roots for all of us. And when we tell about the molars, the number of roots of molars, upper and lower, we mean only first and second molars, without the third molars. And I have to tell you that each root has their root canal. You can find, and you can, for example, with endodontic microscope, or you can find when you will prepare the pulp chamber, the root canals, which will be maybe additional additional root canals. It can be additional root canal or lateral root canal, but in 50% of cases, you will find the quantity of root canals which will be the same quantity of roots. For example, the first upper molar, which has 3 roots, 2 buccal and 1 palatinal, you can find 3 root canals, 2 buccals, mesial and distal, and 1 palatinal canal in the palatinal root. Relatively, the lower molar, which you can see on the screen, you can see the mesial radix or root, distal radix or root, and in this teeth you will find 3 root canal. It is the features of the lower molars. You will find 2 root canals in the mesial radix, lingual and buccal, and you can find the 1 root canal in the distal root. It will be distal root canal. Today I told you only about the features of tooth anatomy, which you have to know in your further practical activity. If you don't have the questions, I'll tell you about the main signs of teeth, and we can finish our lecture for today. Signs of teeth. There are 3 main signs of teeth. It's crown and signs. Signs of the crown. Curvature and sign of the root, curvature, crown and signs, expressed by a greater curvature on the part of the vestibular surface of the crown, located near its medial edge, and a gentle slope of part of the vestibular surface at the distal edge. This is crown angle curvature. Line of the crown curvature, this line of the chewing edge of the tooth along the vestibular side when moving to the mesial surface forms a smaller angle than when moving to the distal. The signs of the root curvature of the entire roots or its apex in the distal direction relative to the longitudinal axis of the tooth. These signs of teeth you have to know for the aim to restorative. When you want to repair the teeth structures, external teeth structures, with artificial, for example, crowns or artificial filling or with the filling material, you have to remember first of all the crown angle signs, because this is the base of your professional understanding and professional restorative techniques. Thank you for attention.